will now officially start the monthly clinical meet. Good evening and welcome all to the second monthly clinical meet, which is being hosted by MVJ Medical College and BGS Global Hospital. And I first begin the program by welcoming our President, Kumar, with the medallion.
Thank you, everybody. Welcome to this meeting. So, Dr. Sudarshan,
hi.
It was a very nice discussion. You were a very good moderator, and the topic discussion was very, very good. Okay, thank you very much.
Somebody's internet is slow.
So let us go to the main functions today. Poster presentation. We have 10 posters and 5 paper presentations. So the poster session will start now, and we have the judges for this is Sagar. Dr. Sagar is the judge for the poster session, and Dr. Sunil Kumar and Dr. Hosmukan is for the paper session. And we will end the poster session rightly by around 6:30, and followed by there is a small new segment which has been added as the recent advances, which I will be presenting, followed by the paper presentation. And I request that all the PGs stick on to the timings, which is for the 3 minutes, and let us not drag it or make it short. Let us try to be as ideal as possible with the timings. So I hope the host here, somebody is maintaining the time. We will also try to maintain the time here. So let's keep on time, and let us start the poster session. And I request again Dr. Sudarshan sir and Dr. Nagbhushan sir to please take over and conduct the poster session and the paper session.
Thank you.
Did you announce the judges?
Yes, sir. I announced.
Okay, thank you.
Yes.
Thank you, sir. And good evening to Dr. Nagbhushan. I think sir has already come on.
Good evening. This is Dr. Neil Shetty.
Hi. How are you?
Fine, sir.
Okay. So shall we go ahead and start with the first poster?
Yes, we are ready here.
Okay. The first one is by our second year PG, Dr. Suhas, and he'll be talking about, yes, go ahead with the topic. Malrotation of the twist.
Good evening, everyone.
The timing, please.
I'm Dr. Suhas, second year postgraduate in surgery department of Mvjmc and RH. Today, my poster topic is malrotation with a twist. Thank the president, the honorary secretary, and the board members, and I would like to thank our HOD, Dr. Sudarshan P, for giving me this opportunity to present this poster. My poster topic is malrotation with a twist. A 12-year-old adolescent female who presented to the casualty at MVJMC and RH with the chief complaints of pain abdomen since 2 days, sudden onset, moderate grade, diffuse in nature, intermittent, colicky night, vomiting since 2 days.
Can you make it?
Sir, it is hanging when we go to slideshow.
Okay.
We are not able to take you to slideshow. It's hanging over here.
Okay.
Can I continue, sir? Can I continue, sir?
Please continue, doctor. Please continue.
Okay. Vomit days, 10 to 15 episodes, non-projectile, bilious, obstipation since 2 days, history of similar complaints 5 months back, which resolved after conservative management. On examination, general physical examination, an adolescent female patient who is moderately built and poorly nourished, vitals, pulse 110 beats per minute, BP 110/70 mm mercury, temperature 98.4 degree Fahrenheit, abdominal examination revealed uniformly distended diffuse tenderness present, bowel sound sluggish, cardiovascular system S1, S2 heard normally, respiratory system bilateral normal vesicular breath sounds present. With the above history and clinical features, provisional diagnosis of acute small bowel obstruction was made, and further the patient was evaluated. Coming to the investigations, hemoglobin was 13.4 gram per deciliter, total counts was 9,160, serum electrolytes sodium was 136, potassium was 3.3. Rest of the blood investigation were within normal limits. A text abdomen was done, which showed multiple air fluid levels with dilated bowel loops. Noted. CCT abdomen and pelvis was done, which showed localized cluster of proximal ileal loops in the midline with maximum caliber of 3.8 centimeters. Oral contrast is not entering beyond proximal jejunum. With the above findings, patient was taken up for the emergency laparotomy. Intraoperatively, abdominal cocoon was noted, encapsulating the small bowel with ascending colon. Dilated proximal jejunum was seen up till 5 cm proximal to ileocecal junction. Cecum was noted in the midline. Intraoperatively, there was fully a malrotated gut, no retroperitoneal fixation of ascending colon. Intraoperatively, dense bands of the abdomen extending from the root of the mesentery up to the pelvis was released. All by intrabowel fibrinous bands were released. Appendicectomy with cecopixy was done.
Somebody please mute it. And doctor, it is 3 minutes is up.
Histopathological examination showed appendix, showed fibrinous obliteration of the appendix. Coming to the discussion, intestinal malrotation represents one of the most common congenital anomalies of the gastrointestinal tract encountered by surgeons. Classic malrotation, also known as non-rotation, is the most common form. Reverse rotation, in which the duodenum and superior mesenteric artery are anticolic rather than retrocolic, may present with transverse colon obstruction. In 1936, William Lett described the surgical procedure for correction of malrotation and midgut volvulus that continues to be used currently. Lat procedure includes broadening of midgut mesentery, division of lat bands, placing the small bowel on the right
Your
abdominal.
time is up. Your time is up, and there is 1 minute left.
Coming to the conclusion, in this case, yes, sir. Yes, sir.
Okay. I request the judge to please discuss if we have any discussion to be done. Dr. Sagar, any questions if you have? Any other questions from even the audience can be put across in the chat box. I can ask here. Dr. Sagar, any questions or shall we go to the next?
No, sir. Yeah.
Okay, thank you. Okay,
Thank you.
we'll go to the next presenter. Thank you, doctor.
Dr. Neil.
Dr. Neil, the timings for the poster is 3 minutes plus 2 minutes for discussion.
Okay, sir.
So it will be ideal if somebody can keep a track of that there with the bell.
Sure, sir.
Good evening, everyone. My topic is, my poster topic is Encysted Hydrocele of Spermatic cord in a 4-year-old child.
Hello.
Clinical presentation: a 4-year-old male patient present with complaints of swelling over right inguinal quarter region since 15 days. Examination: patient conscious and oriented, pulse rate 74 beats per minute, BP 110/70. Local examination: transilluminate fractured cystic swelling over right inguinal quarter region of 3 into 2 centimeter with testis palpated separately from swelling and penis pushed to opposite side. No cough impulse present. Radiological investigation: USG shows cystic swelling noted along the course of spermatic cord extending from inguinal canal to the root of right scrotum with few internal echoes. No evidence of communication with peritoneal cavity. Operative findings: Sac filled with clear fluid was noted along the course of spermatic cord. Sac was separated from cord and excised. Discussion. Fluid collection in a portion of patent funicular process part of tunica vaginalis. Portion of funicular process of tunica vaginalis persists and remains patent and shut off from the tunica vaginalis below and peritoneal cavity above. Swelling in inguinal or inguinous scrotal region, fluctuant swelling, transilluminate positive, above the swelling positive, no impulse of coughing, testis palpated separated from the testis, traction test, testis pulled down, the swelling comes down and becomes immobile. Differential diagnosis, epididymal cyst, inguinal hernia, lipoma of cord, treatment of choice, excision of cyst. Thank you.
Any questions, sir?
Next, okay.
Thank you, sir.
Any questions from anybody? Dr. Sagar?
Oh, sir, no, sir. Yeah.
We are going ahead to the next one, sir.
Please introduce yourself, gentlemen.
Good evening, everybody. Myself, Dr. Prashanth. I'd like to thank President, Secretary, Surgical Society, Bangalore, and HOD, MVJ Medical College, Dr. Satishan Pri, for giving me the opportunity to present the poster. My topic is Mesenteric cyst, a rare intra-abdominal tumor. History. A 65-year-old female patient came with complaints of abdominal distension since 3 months and pain abdomen since 1 month. No bowel and bladder alterations. Per abdomen, on inspection, fullness is noted in the right hypochondrium. Palpation, soft, smooth surfaced, non-tender, oval intraoperative occupying the right hypochondrium, epigastric, and the right iliac region, with the inferior and medial border well palpable, side-to-side mobility present, not moving with respiration. On auscultation, bowel zones are present. CVS S1 S2 for RS bilateral air entry present. On investigation, HP 15 gram per year. Blood picture and other investigation within normal limits. ESG suggestive of hepatic cyst with differential diagnosis peritoneal inclusion cyst, serous sanguineous cyst due to trauma, Hydrocele cyst, CECT abdomen and pelvis, a thin walled cystic lesion measuring approximately 14 into 10 into 5 centimeters with clear contents in the subhepatic region.
Okay.
Exploratory laparotomy was done. A cystic lesion of 15 into 15 centimeters seen in the right hypochondrium, extending from the inferior surface of the liver to the right iliac fossa with smooth serous wall. Hydrocelis done along with the ascending and transverse colon with the sequential hemostasis. Pedicle located at the level of the mesenteric root was sutured and the cyst was completely excised with intact capsule. Histopathological examination revealed a fibrous collagenous cyst wall lined by a single layer of flattened ciliated cuboidal epithelium with few congested blood vessels, suggestive of mesenteric cyst, a benign serous cystadenoma. Discussion. Mesenteric cyst are rare condition. Incidence 1 in 2 lakh to 3.5 lakhs. More common in females. Mesenteric cyst is defined as a cyst located in the mesentery having a recognizable lining of endothelium or mesothelial cells, often asymptomatic and found incidentally. Some patients may present with unspecified abdominal pain, sensation of abdominal mass, abdominal distension. Treatment is indicated in symptomatic patients. Increasing size will increase the risk of complication. Complete excision by the laparoscopic or open technique is the gold standard to prevent recurrence of malignant transformation, which occurs in about 3% of cases. The interest of this case lies in its rare incidence. Mesenteric cyst poses a diagnostic challenge for the surgeons, and they should be considered in differential diagnosis. Physical examination imaging do not always provide diagnosis. Surgical management should be advised due to the potential complications if untreated. These are my references. Thank you.
Any questions, sir? We'll go ahead to the next presentation. Stop sharing. Stop sharing.
Please introduce yourself.
Good evening to one and all present here. I'm Dr. Sujith M, second year surgery PG from Mvjmc and RH. I would like to take this opportunity to thank the President and the Secretary and HOD Dr. P. Sudarshan sir from Mvjmc and RH. This of surprise. Patient was Mr. Jafarullah Khan, age 55 years old, male, very umbilical abdomen since 10 days, moderate to severe grade colicky type, aggravated after food. History of distension of abdomen since 4 days, which was associated with vomiting since 1 day with 4 to 5 episodes containing food particles, non-bilious and non-blood tints. Past history, history of CVA 20 years back, right-sided with right-sided hemiparesis, which were resolved on regular treatment. Chronic smoker since 25 years. No history of previous abdominal surgery. On examination, patient was conscious, oriented. Temperature was 99 Fahrenheit. Pulse rate 100 beats per minute. BP 160 by 100 mm of Hg. SpO2 94% on room air. Per abdomen examination showed inspection, abdominal grossly distended, no scars, palpitation, diffuse tenderness, guarding and rigidity was present. Percussion, no obliteration of liver dullness. Auscultation, bowel sounds were absent. All the rectal examination was normal. Rest of the systemic examination was within the normal limits. Investigation, CBC, RFT, serum electrolytes were normal. Although there was deranged LFT with raised total bilirubin and ALP, raised coagulation profile. Erect abdomen showed multiple air fluid levels. USG abdomen was suggestive of a small bowel obstruction with moderate ascites. CECT showed thinned out walls of the gallbladder with gross ascites. Here we can follow the splenic artery, and at this level we are supposed to visualize celiac axis, which is absent, indicating of complete thrombosis. And here we can see multiple air fluid levels. A patient was immediately posted for emergency. So a gangrenous gallbladder with a bilious peritoneal fluid, approximately 2 liters was aspirated, but was inspected with gangrenous changes, which are dark patches. Procedure, cholecystectomy was done, resection and anastomosis of jejunum and ileum, thorough wash was given, subhepatic and pelvic drain placed, HP was sent. Postoperatively, patient was treated with IV antibiotics, analgesic, DVT prophylaxis, 4-point FFP transfusion. Postoperative events. Bilious drain was observed from day 1 to day 2. IBD starting for biliary gangrenous changes.
Hello.
Mesenteric.
Yeah. What was your
Mesenteric. Yes, sir.
Yeah. Discuss. Continue.
Mesenteric ischemia can be classified as acute and chronic ischemia, usually presented in patients aged above 55 years old, mostly involving males with history of smoking or recent cardiac surgeries, trauma, obesity, or hypertensive status. Acute ischemia is usually presents with or without occlusion, venous or arterial, usually central or peripheral involved. Most commonly affect SMA due to thrombus, atherosclerosis, arterial fibrillation, PAO, polyarteritis nodosa. In setting of AMI, that is acute mesenteric ischemia, gangrenous cholecystitis has been reported. As the cystic artery is a terminal artery with no terminals, however, the presentation is rare. In our case, a patient presented with AMI manifests as a bowel infraction along with gangrenous cholecystitis, and the later was an intraoperative. These are my list of references. Thank you.
Any questions, sir?
What was your pre-op diagnosis clinically? Did you able to diagnose the thrombosis?
No, sir. Clinically, it presented as a small bowel obstruction, sir.
And what is the short gut syndrome? What do you mean by short gut syndrome? Short bowel syndrome? How much bowel was resected? What was the length?
Larger segment was 86 centimeter and smaller segment was 26 centimeter. So that was approximately 105 centimeter.
So what about this thing?
Yes, sir. Yes, sir. He's still alive, sir.
Okay, fine. Next.
Thank you, sir.
So this patient has been coming up for regular follow-up and is doing well right now. Post
Okay. Yeah, fine.
Thank you.
Thank you, sir.
Good evening, everyone. I'm myself, Dr. Jahid Hussain, Mvjmc Medical College. I'm hereby to thank Secretary and President of Surgical Society and HOD of our department. My posted presentation topic is sigmoid volvulus in an adult. Clinical presentation. 21-year-old male patient presented to casualty with complaints of severe pain abdomen over left upper quadrant since 4 days, aggravated after having food, and vomiting, 3 episodes containing food particle, non-bilious and not blood-rich, and complaints of constipation since 2 days. On examination, patient was conscious and oriented and tachycardic and hypotensive. Her abdominal examination shows distensions of abdomen over left hypochondral region and umbilical region, and diffuse tenderness was noted. Tympanic note on percussion and auscultation shows sluggish bowel sounds. Digital rectal examination shows empty rectum, and other systemic examination are within normal limits. Radiological investigation, erect abdomen X-ray shows dilated loop of colon with coffee bean sign, and patient was provisionally diagnosed to be sigmoid volvulus and planned for emergency laparotomy and procedure. Operative findings: midline laparotomy incision taken and abdomen opened in layers, dilated sigmoid colon with viable bowel noted, and torsion of sigmoid colon more than 180 degree. Narrow sigmoid mesentery was noted. Detorsion of sigmoid colon was done. Flatus took place perectally and decompression done, and contents to be liquid diet. Sigmoidopexy was done. Discussion: valvulus twisting or axial rotation of portion of bowels about mesentery. Torsion more than 180 degree cause obstruction of the lumen. Torsion more than 360 degree causes vascular occlusion in mesentery. Valvulus most commonly involve small intestine, cecum or sigmoid volvulus. Sigmoid volvulus is the most common cause of strangulation of the colon. Predisposing factors of sigmoid volvulus: long pelvic mesocolon, narrow attachment of pelvic mesocolon, and overloaded pelvic colon. when the sigmoid colon twists axially around the narrow base of mesentery, leading to a closed loop of bowel that is at risk of strangulation, ischemia, gangrene, and perforation. X-ray abdomen investigation part, X-ray abdomen, dilated loops of abdomen, two limbs are seen running diagonally across abdomen from right to left, and bare minima will show ace of spade or bird beak appearance. CCT abdomen pelvis, dilated colon with air fluid level, and Bowel sign with represent twisted colon and mesentery. Treatment part, emergency treatment, endoscopic derotation should be done. Failure results in early laparotomy with untwisting of loop and perineum decompression. Definitive management, if bowel is viable, we can go for sigmoidopexy, but it is not preferable due to high recurrence rate. So sigmoid resection and anastomosis is preferred on elective basis. If bowel is not viable, we have to plan for sigmoid resection followed by Hartmann's or palmicolic surgery. Thank you.
Hello, this patient is, what is the age of the patient?
21-year-old.
21 years old. You would have gone for sigmoid resection and anastomosis. There is high chance of recurrence again, once again. Once again, you have to do laparotomy and all.
The patient was, at the time of presentation, he was tachycardic and hypertensive, vitals are not stable. And so in intraoperative also, he developed this hypertensive, so we couldn't go for this sigmoid resection.
If patient is in shock, what maximum we can do is resect and do stoma and come off. So that is one option.
And bowel is also
bowel was healthy. You were saying bowel was healthy, so you were planned for just sigmoidopexy. Okay, fine, no problem. Next.
Hello, hi, good evening, everybody. We will have a couple of minutes break because we need to upload one of the presentations. Hope you don't mind. Stay with us.
No problem.
Evening, everybody. We come to the second part for the poster presentation. I would leave the floor open for Dr. Rehana to start off with the presentation. She's one of the postgraduates from Ggh&Gims. On to you, Rehana. And once again, I am sorry for the short delay. Thank you.
Good evening, one and all. I would like to thank Dr. Madan sir, my HOD sir, Dr. Nagbhushan sir, Dr. Neil Chetty sir, and Surgical Society of Bangalore for giving me the opportunity of presenting an e-poster. My poster for today is carotid body tumor, a challenging lateral neck mass. A 22-year female has presented with complaints of painless static swelling in the right side of the neck for the past 9 months. On examination, there was 4 × 3 centimeter swelling noted in the carotid right-sided carotid triangle, which was fixed, which was pulsatile, form in consistency. Clinical suspicion was of right carotid body tumor. Patient was advised for USG neck and MR preoperatively MR angiography was done for this patient. MR angiogram of this patient depicts the Liar's sign, which is basically splaying of internal and external carotid artery as shown here. Treatment opted for this patient was excision biopsy with anticipated vascular reconstruction. Here are the intraoperative images. Intraoperatively, external carotid artery, internal carotid artery were preserved, and the hypoglossal nerve, vagus nerve, and the glossopharyngeal nerves were preserved after meticulous dissection. On histopathological examination, the images showed Zilbalin pattern of cells, and his immunohistochemistry was positive for phenaptophysin and S100 as shown in the figure. Carotid body tumors are rarest neoplasms with an incidence of 1 to 2 per 1 million population. These carotid body tumors, basically majority of the tumors present as asymptomatic lateral neck mass below the angle of the mandible. Patients might occasionally present with pain, difficulty in swallowing, hoarseness of voice. Some of the differential diagnosis of the carotid triangle swellings include lipoma, vagal schwannoma, vagal neurofibroma. On clinical suspicion of carotid body tumor, diagnosis should always be confirmed with CT or MR angiography. Carotid body tumors are basically of neurocrest origin. The other sides of paragangliomas are neck, parapharyngeal spaces, mediastinum, retroperitoneum, and adrenal medulla. The invoked etiology for carotid body tumors in majority of the cases is hyperplasia, which is secondary to chronic hypoxemia. Shamblin and Mayo Clinic, they have classified the types. Tumor type 1, which is basically less than 5 centimeter and relatively free of vessel involvement. Tumor type 2, which is intimately involved, but it doesn't encase the vessel wall. Tumor type 3, which is intramural and encases the carotid vessels and adjacent nerves. Treatment for shambling type 1 and shambling type 2 is surgical excision. Shambling type 3, it requires preoperative embolization, surgical excision with anticipated vascular reconstruction. Here are my references. Thank you.
The poster is open for discussion.
What are the symptoms the patient came with? What are the symptoms?
Painless right-sided lateral neck swelling of 9 months duration.
So what made you to do investigations, MR angiogram on? What were the initial investigations you have done for this patient?
USG neck and MR angiogram data. Sir.
What did USG report say?
USG report hypercoagulation and suggestive of carotid body tumor.
Okay, fine. So then a plan for the
Yes.
Fine. Thank you. Yeah.
Thank you. Good evening, everyone. I'm Dr. Risha, postgraduate from Ggh&Gims. I would like to thank my HOD, Dr. Madan sir, and Dr. Nagbhushan sir for their valuable guidance and support. My case is a rare cause of recurrent subacute intestinal obstruction. My patient is a 65-year-old lady with history of colicky abdominal pain on and off for the past 1 year. On examination, her abdomen was soft, tender with hyperperistaltic bowel sounds. Digital rectal examination showed a roomy rectum with fecal soiling. CCT abdomen and pelvis showed a long segment proximal jejunal wall thickening with luminal narrowing as shown in figure 1, and the figure 2 and 3 showing the dilated proximal bowel loops. This is a CT image of the patient which showed that the liver is normal, and the red arrow showing in the subsequent images the dilated bowel loops, and the yellow arrow showing the narrowed jejunal segment with the luminal narrowing as shown here. With the clinical diagnosis of recurrent subacute intestinal obstruction, patient underwent exploratory laparotomy, and intraoperatively there was a 1.5 into 1.5 centimeter lesion in the jejunum, about 20 centimeter from the DJ flexure, and a stricture segment was noted in the proximal jejunum, 40 centimeter from the DJ flexure, attached to thickened mesentery. A double segmentary resection anastomosis was done. The histopathology of the surgical specimen was reported as well-differentiated neuroendocrine tumor of the jejunum of grade 1. The first two images show the 4x and 40x image of the specimen, showing the tumor cells arranged in insular, organoid, and solid sheets and nests. And the first lesion, which was the proximal jejunal lesion, was reported as combined gastric and pancreatic choriostoma. This is the images showing the 10x and 40x images of the pancreatic cells. Immunohistochemistry confirmed the diagnosis with the positive chromogranin A and synaptophysis. Post-operative recovery of the patient was normal. Her 24-hour 5-hydroxyindole acetic acid levels and serum serotonin levels came out to be normal. She was on regular follow-up for 6 months, and patient was asymptomatic. Coming to discussion, GI carcinoids are rare neoplasms constituting about 0.5% of all diagnosed cancers. The most common site being small intestine, that is about 45%. And among the small intestine carcinoids, jejunum is a rare site with less than 6% of cases. These are typically slow-growing tumors with vague symptoms such as intermittent abdominal pain for chronic duration. The peak incidence is seen in the 5th and 6th decade of life. The average time of onset from symptoms to diagnosis exceeds 9 years, according to a study. The treatment is resection and anastomosis in cases of GI carcinoids. Combined gastric and pancreatic heteropias are rare and reported mainly in the duodenum, jejunum, and ileum, with the incidence less than 1% to 13%, and are incidentally found in the intraoperative period. And treatment is only if they are symptomatic or found intraop. These are my references.
Poster is open for discussion.
So, clinically, patient presented with recurrent intestinal obstruction, this patient.
Yes, sir.
What are the other sites where you can see, which is the most common site in the bowel, you can see carcinoid tumors?
Appendix and the terminal ileum, sir. The last 30 centimeter of the ileum.
Okay, fine.
They're also seen in the stomach, colon, and rectum. Also.
Yeah, fine. Okay. Okay, fine. Next.
Good evening, everyone. I'm Dr. Srivatsa, postgraduate from Ggh&Gims. I would like to thank Dr. Madan Sam HOD and Dr. Nagbhushan sir for the valuable guidance. 27-year-old female patient came with an expelling since 6 months, which was firm, non-tender, solitary swelling of 4 into 3 centimeters. Carotid pulsations were normal, and the clinical diagnosis were cervical lymphadenopathy. The neck ultrasonography showed the features of possible benign neurogenic lesions, and FNA was inconclusive. And the MRI showed a lesion which is displacing the jugular vein laterally and the carotid artery medially. And surgical excision was done under general anesthesia through the transcervical approach, where incision was taken around 3 centimeters below the lower border of the mandible. The diagnosis of vagal schwannoma, right carotid triangle. The HP showed Antony A and Antony B areas, where Antony A shows spindle cells arranged in a palisaded manner, and Antony B area which shows the fewer cells, and the compact nuclei which is arranged in a palisade manner like Verroque bodies, which is suggestive of schwannoma. Post-operatively, patient developed hoarseness of the voice and cough. The patient is on steroids and speech therapy and currently improving. Schwannoma, the benign tumor with sporadic malignant degeneration arising from the cranial, peripheral, and autonomic sheath cells. Head and neck localization being rare, and vagus nerve involving is the rarest incidence. Usually patients present with hoarseness and paroxysmal cough on palpation or on during the FNA, which is unique to the vagal schwannomas. Intracapsular enucleation with nerve sparing techniques is the treatment of choice. Post-operatively vocal cord palsy, which is a most common complication with an incidence of 85%. Treatment of post-operative nerve palsy should be regarded as a part of management of schwannoma. Thank you.
The poster is open for discussion. Thank you. Thank you, sir.
Good evening, everybody. I'm Dr. Madhusudan, postgraduate from BGS Global Institute of Medical Science. I would like to thank Dr. Madan, my head of the department, and Dr. Nagbhushan sir for the valuable guidance. My posted topic is a rare case of recurrent swelling in the left cheek. 62-year-old female patient who is hypertensive and diabetic, presented with swelling in the left cheek since 2 months. Patient had underwent excision with recurrence 8 months back. On examination, bidigitally palpable nodular swelling in the left cheek, measuring 4 × 3 centimeter, with no ulceration or palpable lymph node was seen. Ultrasonography of left buccal mucosa showed multiple hypoechoic lesion, largest measuring 2.5 × 1.2 × 1.2 centimeter, with satellite lesion, which was suggestive of minor salivary gland tumor and nerve sheath tumor. FNAC of the swelling showed metachromatic matrix spheres with sharply defined borders surrounded by basaloid tumor cells. An OPG was done, which showed no bony involvement. Patient underwent wide local excision of the swelling with 2 centimeter margin with rhomboid flap closure. Microscopy showed basaloid cell borders with mild pleomorphism. Perineural and lymphovascular invasion were noted. Histopathological examination features were suggestive of invasive malignant epithelial tumor. Immunohistochemistry was positive for CD117, P40, and P63, which was suggestive of adenoid cystic carcinoma solid variant. Patient was on a regular follow-up, and after 6 months follow-up, she was asymptomatic. Coming to discussion, minor salivary gland tumors are rare with significant heterogeneity. The most common site for minor salivary gland tumor is palate, followed by cheek, floor of the mouth, and retromolar area. Adenoid cystic carcinoma is a rare malignancy, accounting for 1% of all malignancies of the neck region. Complete resection of tumor is a mainstay of treatment. 5 to 10 year recurrence rate is 75%. Thank you.
So what are the other regions where adenoid cystic carcinoma can occur in the body?
Trachea, breast.
What is the most common minor salivary gland tumors you see usually? Most common minor salivary gland tumors. One is adenoid cystic carcinoma. What are other tumors you can see?
Epithelial myoepithelial carcinoma, basal cell adenocarcinoma.
Okay, fine. Next.
Thanks.
Yeah, I'm here to present a case of giant rectal fecaloma under the guidance of Dr. Nagbhushan sir and Dr. Neil Shetty. A fecaloma is a rare cause of subacute intestinal obstruction, usually seen in rectum and sigmoid colon. It is basically a large fecal mass that has undergone calcification over years. The presentation is of vague abdominal discomfort. We hereby describe a case of 30-year female who presented with a fecaloma in the rectum and sigmoid colon following a defunctioning ileostomy after she underwent multiple abdominal surgeries for imperforate anus in childhood. Yeah, fecaloma is a hard calcified immobile mass of feces usually noted in rectum and sigmoid colon. It is an extreme form of fecal impaction, giving it an appearance of tumor on imaging. It is more commonly due to neurogenic bowel dysfunction, as such Hirschsprung's disease in children, imperforate anus, and anal stenosis. Symptoms vary from mild abdominal discomfort to an acute abdomen, from stercoral ulcer perforation at the site of impaction to an acute intestinal large bowel obstruction. The usual treatment in short duration of fecaloma is use of laxatives, hyperosmotic enemas, and they even respond well to PEG preparations. Manual evacuation can be tried when the fecaloma is in the lower rectum. Colonoscopic fragmentation and removal can also be tried. Surgical options are reserved in patients who fail to conservative management, which includes colotomy and evacuation, colectomy, or rectosigmoidectomy. The characteristics of fecaloma, as mentioned on imaging, is a misnomer for that of malignancy. We had a patient who was 30 years female with history of multiple abdominal surgeries, at least 4 during her childhood, for imperforate anus and rectovaginal fistula. She was left untreated until the age of 5 due to financial restraints, following which she had undergone a diversion colostomy, which was closed in 2000 when she was 8 years old. The patient to have a very normal life until 2013, when she underwent a ileostomy for recurrent episodes of subacute intestinal obstruction. We are assuming it could be because of a stomal stenosis. In July 2021, she had come to our OPD with a recurrent pain abdomen and vomiting. On evaluation, CT imaging, the patient CT showed a giant mass measuring around 10 into 8 centimeters in the rectosigmoid junction with multiple pockets of air and laminating areas of calcification consistent with the findings of fecaloma. CT also showed a stomal stenosis with parastomal hernia associated with features of subacute obstruction. So we can see a large fecaloma occupying the pelvis, which was around 10 centimeters in the diameter.
Hello?
Yeah, basically the patient was posted for surgery in the view of ileostomy stenosis and subacute intestinal obstruction. She underwent explorative laparotomy with rectosigmoid resection with evacuation of fecaloma. Stomal site resection was done along with side-to-side ileoileal anastomosis and end colostomy. Intra frozen section was sent prior to performing the colostomy to confirm presence of ganglionic cells. This was what we done in the OT. The ileostomy was continued back with the distal part that was around, it was 8 centimeters distal to the ileocecal junction. And the rectosigmoid part with the fecaloma was resected, and it was bought as end ileostomy. Sorry, end colostomy. I'm sorry, it was bought as end colostomy. Around 600 grams of fecaloma was evacuated. As informed earlier, fecaloma is impaction and extreme variety of impaction due to accumulation of feces. The mass is separable from the rest of the bowel contents. It is not uncommon condition as such, but it is an underreported condition. It is most commonly seen in pediatric and geriatric age group. It is due to ganglionic cells in the distal colon and rectum. The composition of mass is quite inconsistent. It is often formed by the laminated fashion due to deposits of calcium salts. The complications can include subacute, acute intestinal obstruction, stercoreal ulcers leading to perforation. Rare cause of hydronephrosis due to external compression was also seen. Conservative management is usually tried. Once the conservative management fails, then is when surgical intervention is warranted. So conclusion is that fecaloma should also be considered as a differential diagnosis in patients with history of chronic constipation or features of subacute intestinal obstruction. Usually resection anastomosis is advised rather than colotomy because long-standing impaction can lead to multiple stercoreal ulcers. There is no much literature on this. Hence, optimized clinical evaluation and multidisciplinary team approach should be considered in each and every case for appropriate therapeutic benefits. Thank you.
Dr. Sagar, yeah, any questions?
No, sir. This is also part of the poster. So this is also.
If there is no questions, shall we go ahead?
Yes, yeah. Please.
Okay.
Thank you, one and all.
Thank you, doctor. So thank you for all the postgraduate students for the wonderful poster session. It was indeed quite interesting posters. And before